Good afternoon. My name is Candace Cousins-Hopkins, and I am the Assistant Director of Marketing for Special Events here at St. John's Riverside Hospital. I'm so glad you were able to join us today for our webinar on breast cancer awareness. It's such an important topic, as you all know, especially during Breast Cancer Awareness Month, which is October. And so there's always something new to learn about prevention, screening, and treatments, and so it's going to be a very special presentation today. Before I introduce our guest speaker, I would like to acknowledge our partners, Sally Pinto, who's from the Yonkers Nork, which is the neighborhood naturally occurring retirement community that is under the umbrella of the Yonkers Office for the Aging and Westchester Jewish Community Services. Nork provides programs, activities, and services, including nurse and resource specialists to seniors 60 plus living in Northeast Yonkers. We also have Z Baird from the Yonkers Public Library, which has 3 locations here in Yonkers, the Riverfront, Will, and Crestwood. Please visit their website for hours of service, free programs, downloadable books, streaming movies, and more at www.ypl.org. Now I would like to introduce our special guest, Dr. Nidhi Sahgal. Dr. Sahgal has 19 years of experience serving patients who have breast diseases. She practices in Yonkers and has been affiliated with St. John's Riverside Hospital for the past 7 years. She is a wonderful resource, a wonderful doctor, and we are so thrilled that she could be here today for this presentation. So Dr. Sahgal, whenever you're ready, please go ahead. Thank you.
Thank you very much, Candace. Good afternoon, everyone. Hope everyone's having a nice day so far. 2020 is certainly going to go down in history for many, many different reasons, as we all know. And because it's October, we wanted to do something a little bit, as usually I do these talks, of course, in person, but virtually perhaps we can reach out to many more women and people. To be, hopefully this will be educational. I'm going to touch on some preventative techniques, screening, how do we treat some forms of breast cancer, and a little bit about genetics as well. I think most women know that there are about 250,000 new breast cancer cases a year in the United States, and if somebody had to look at those numbers, it would come up to almost 1 in 8 women may be dealing with an invasive breast cancer a year. So that's significantly high enough, and we find this is a very important area where we can do something about perhaps either preventing or perhaps at least finding it early, where we would have better cure rates. So to first talk about prevention, it's not a very hot topic that's written about or researched a lot. But I think for most women, we pretty much know that diet and exercise are 2 things we can somewhat control. And diet means a high fiber, low fat diet, which certainly keeps a lot of different diseases away, and also keeps away breast cancer. And actually even for prevention after you've had treatment for breast cancer. The other is exercise, which doesn't have to be vigorous exercising, but certainly 1.5 hours of moderate exercising a week has been shown to decrease risk of breast cancer. The next part we'll talk about, which is a lot more to talk about, I think, is screening, which is on every woman's mind and a lot of women's mind in October, where when should I have a mammogram? If I should have a mammogram, should I have a sonogram? What is a mammogram? That sort of thing. So some of this information might be redundant. Some hopefully will be educational, where we all know a mammogram is an X-ray of the breast. It's done in lots of outpatient radiology settings and certainly at the hospital as well. Most facilities at this time have what's called digital mammography. And some of the facilities, including St. John's, we have what's called 3D mammography. And I'll get into it a little bit about what that means. A mammogram is 2 X-rays of each breast taken, I know feels like a breast squished like a pancake because you're making a 3D structure into a 2D structure, and that's the reason for that compression. And though I know it is a very uncomfortable test, we just had that discussion, our pre-talk, but it really is the one test. I have many studies showing there's improved survival in women, makes them live longer. And also it's the one test I have that can find changes before breast cancer happens, which is a very important point, where breast ultrasound is an excellent tool used at times, but it's not going to find changes in the breast tissue before a cancer has already been made. So I'm trying to identify women who have these changes in the breast tissue that may tell me that this is a person who I should be watching more carefully, perhaps has an increased risk of a breast cancer, or may develop into a breast cancer in the future. So I do believe mammography is really the one way where I can get a lot of information relatively quickly. I know it's a little uncomfortable, but I do think it has its limitations. It's not a perfect test. There's not too many perfect tests we have. So it has to be put together with a discussion with the patient about their family history, as well as an exam done by a clinician, and whether it be your regular family doctor or MP or GYN. So put that all together, I kind of wanted to go over again what an X-ray kind of feels like. I'm sure most women who've had one can vouch for the pressure that they feel when they have a mammogram. But funny enough, the more pressure they give, the clearer the picture gets. So it does make it, and you actually use less radiation in some ways because you won't need additional imaging. So though as it is an uncomfortable test, I would definitely promote that women should go in and have a mammogram of the breast. As to when to have the mammogram certainly has been debated for many years, but I'm going to try to put it succinctly. There's two societies I follow, which certainly is the American Cancer Society, others the American Society of Breast Surgeons, and the guidelines are pretty much similar, but the hard part to figure out, and this is really where your doctor is going to have to come and step in and say, what is your risk for breast cancer? So we look at an average risk woman. What that means is someone who doesn't have a strong family history, who hasn't had nodules and biopsies and problems in the past with the breast. The guidelines are essentially that any woman over the age of 40 should be offered a mammogram, and everyone over the age of 40 should have an annual mammogram. American Cancer Society says after the age of 55, you can actually go to every 2 years if, again, average risk women. That's a very important statement to end with, where if you don't know the entire history of the patient, it's going to be hard to say to stop mammography or do it only every 2 years at 55, knowing that breast cancer risk increases with age on an annual basis. The other interesting question is, when do you actually stop doing mammography? Actually, nobody knows. Essentially any woman who has a lifespan of at least 10 years should continue mammography, because we do find that if I can find an early cancer, I can treat it, and so it doesn't become a problem over her lifespan. Certainly the older you are, the cancers are slower to grow. So somebody could argue that there's an age that we can stop, but that's a difficult one to know, and there's no guidelines except for it has to be personalized for each patient by your doctor. I will touch up on something called self-breast exam, which I think it's good for women to know their breasts, and people ask me, well, what am I feeling for? Am I feeling a lump? You're just trying to perceive change. And if you do examine yourself once a month, in women who are menstruating, the best day to check yourself is about 7 to 10 days after the first day of your period. And that's when the breasts are going to be the least lumpy and the least painful too. And really doesn't matter how you examine yourself, if you do the same thing every month, you should be able to learn somewhat what the tissue there feels like. And then if you feel a change, well, it feels more lumpy, the skin looks a little bit red, the nipple looks like it's more painful. There are lots of different symptoms that you could get, the 50 different ones of them, but all you need to do is, if you feel a change, you need to let your doctor know so they can further figure out what else is going on, if anything's going on at all. The next part I'll touch on is, let's say you do have a mammogram, is there reason to have an ultrasound? Women walk around these days with a term which I hear a lot of women think they have a problem, is called dense breasts. What is dense breasts? Dense breast just means that the X-ray of the breast or the mammogram is more white than black. Makes the X-ray a little harder to interpret for the radiologist and for me. And then ultrasound can see through some of that dense tissue. So in young women who, let's say, have an increased risk or have lumps that we're feeling, we sometimes recommend doing a breast ultrasound in addition to the mammogram. If you have a mammogram or an ultrasound, an abnormality is found, that is the radiologist or the doctor calls you, says that they see something, we don't automatically assume that's bad. There's lots of things that show up on mammography and ultrasound. They may well be nothing. In fact, 80% of those are nothings, but they do need to be looked at further. And how we look at those is usually, for the past many years, I've been doing what I call needle biopsies to make a diagnosis instead of having to go through surgery to make a diagnosis. A needle biopsy is done very safely and easily by either the radiologist or myself, either at the hospital, sometimes in the office, where it takes about 2 or 3 minutes to do. We can get some tissue from the area that's of interest, and we send that to the lab. It's very well tolerated. There's only numbing medicine into the breast. You're wide awake, and we get our result back in a few days, and then that way we can have a discussion about hopefully it's all okay, and then you go on to your routine screening. And if something does pop up, at least we're right there to talk about the results and figure out what to do, what will be the next step. The other part I'll touch on is genetics, which is also always in the back of my mind. We talk about genetic breast cancer, and it's been a lot in the media in the last few years, much more than it ever was before when I started practice 19 years ago. And I think the reason is because we are all more aware of our family histories. We have certain gene tests that are now available. But genetic breast cancer is still a very, very small number compared to the breast cancers I diagnose. I always tell my patients, being a woman is the highest risk you have of getting a breast cancer. So though we all perseverate or talk about family history, about genetics, really being a woman is risk. And I would suggest everybody take that seriously, to go have a clinical breast exam by a doctor once a year and to have your screening mammogram if you're over the age of 40. Now, less than 40, we don't have any standard screening, except that you should still have a clinical breast exam, and that should start at age 21, typically. And most gynecologists who are seeing women in those age groups, so most gynecologists are pretty savvy about checking the breast as part of their physical exam. Though, who do I do genetic testing for? So, of course, I see mostly women who already either have problems or have a strong family history. So, there's a lot of young relatives that you see have different kinds of cancers that are linked, such as breast, ovarian, pancreatic, and some other ones as well. And that's when I have discussions about genetic testing. And the test itself is just basically a saliva test. I do this in my office, where I have them spit in a cup, and that's then gets sent off to special laboratories around the country who do this kind of test for me and come up with genes that may be found in the patient, and then we have a discussion about what does this mean, and how do you do risk reduction? How can you decrease your risk if you have a genetic mutation, for example? And that's certainly for another time. So majority of women do not need to think about their genetics, but I would say, again, being a woman is risk. The last part, as far as what is out there in treatment, I think we have ways of finding cancer a lot quicker, easier, with mammography, with ultrasound, with the needle biopsies that we do. We're able to give the results fairly quickly as well. Then we sit down and have discussions about what is the plan of treatment. Usually there's some form of surgery involved if it is a problem found only on imaging. There's sometimes radiation, which we also have right across the street from St. John's, and certainly medicines as well, which so there's 3 different kind of doctors that work together to figure out the treatment plan, which would be a surgeon, which is me. There's a radiation oncologist, and then there's a medical oncologist, and we all kind of work together to figure out what would be the best course of treatment for that particular scenario. Thankfully, most women in this day and age go through treatment and are able to work through treatment, work through radiation, and we can get them through this. And we've been doing that for many years together. And I think there's a lot of hope. I think there's a lot we've done in the past many years for diagnosis and treatment of breast cancer. And I hope that we're going to continue finding even more. So my message is, go have your mammogram. Thank you.
Great. So now we will get into our question and answer portion of the program. You should have a bar where you can write your questions in and they will be published. So please go ahead and start doing that, and we can have Dr. Sahgal answer them. We had one that just came in, Dr. Sahgal. What's your position on breast MRIs?
So breast MRI is an excellent tool. And there's essentially three ways we look at the breast with technology. One we harped on a lot, the X-ray, which is the mammogram. Ultrasound uses sound waves to look at the breast tissue. And then MRI looks at the breast yet another way with a completely different technology, which is it's an excellent tool, and it can definitely be used in many scenarios. It's typically reserved for women who we consider higher risk for breast cancer. In American Cancer Society guidelines, says anybody with a risk of more than 20% in their lifetime can be offered a screening breast MRI. It's a tool we use, we don't take lightly, because though it's a very sensitive test for picking up breast cancer, it will pick it up 95% of the time if there's something in there, but it is very non-specific. That is, stuff may light up, that may be nothing, and then we essentially go chasing. So we do want to use it in the right setting. So the typical setting is either they have an increased risk for breast cancer, or in a young woman that are diagnosed with a breast cancer, I typically do an MRI just to make sure there's absolutely nothing else going on that may not have seen on a usual mammogram or sonogram.
The next question that came in, is it safe to go to the hospital for routine screenings during the COVID pandemic?
That's an excellent question. I think that's on everyone's mind every day. How should I even step out of the house, much less go to a hospital where, you know, there are only sick patients? Well, I think that with all the precautions we're taking while entering the hospital, there's someone taking your temperature, there's Purell stations in every corner. I think as long as everyone's wearing their mask, everyone's doing their hand washing, I think it's very safe, and I definitely think it's now time to get out and do your preventative care.
Great. And then you kind of touched on this, but someone asked, when should I start screening for breast cancer, and how often?
Sure, we can talk about that. I would say any women over the age of 40 should be offered a mammogram. I usually start my first at age 40, and then annually from then on. Not ending until whenever. I mean, I have 90-year-olds still having mammogram because that's the right thing to do for them, but age 40 and an annual basis.
And what is the difference between a mammogram and breast ultrasound, and do we need both?
Right. So another excellent question, because nowadays, so a few years ago, there was a New York State mandate where we have to record the density of the breast tissue, or I should say the radiologist has to write down on the report the density of the breast tissue. Density just means, again, that the X-ray is more white than black, makes the X-ray harder to interpret. And in that particular scenario, the radiologist will put a little thing at the bottom saying, consider additional screening. And that additional supplemental screening is usually an ultrasound of the breast, which can see through that dense tissue and pick up more things that a mammogram can sometimes. The challenge, again, of all of these tests is not only does it pick up more, but those things that they pick up may be nothing. So we do need to make sure that you have a discussion with your doctor as to why are we doing a screening breast ultrasound. I use ultrasound a lot in my practice. It's actually almost part of my physical exam. Let's say I see a young woman who has a lump in the breast. It's easy to put the ultrasound, which uses sound waves and jelly. It's a very sort of a benign test, if anything. It's not squeezing. It's not a painful test where I can easily see the lump on ultrasound and tell the woman whether it's a cyst or something solid or something she doesn't have to think about at all. So it is a very, very excellent tool for that purpose as part of my physical exam. But what you're talking about, I think, is screening ultrasound, which is sort of done randomly looking at the whole breast, just like an X-ray would be done for the whole breast. And those have to be taken with a grain of salt, but I think there is certainly a population where the density of the tissue limits the X-ray. It's reasonable to consider a screening breast ultrasound, knowing that, yes, we may find more things that we may either go chasing or following or biopsying. As long as someone understands that, I think it's a very, very good test.
Thank you. Another question came in. What are the symptoms of breast cancer?
Right. So I'm not fond of that question because there's really no symptoms of breast cancer. Women generally, even when they have a cancer, the largest cancer you can find in the breast, don't feel unwell. They don't feel they have anything wrong with them. As far as feeling goes, there's no feeling of any kind that says, oh, women don't feel ill, they don't lose weight, they're not nauseous, they don't have symptoms that we typically think of other diseases, mostly because it's an external organ. So it's not compressing on anything. The only thing every once in a while they'll get an actual symptom is perhaps pain. Rather than that or sometimes if it's big enough, certainly you can come through the skin, so you get, like a wound essentially. But for the most part, when I talk about symptoms, I usually say, you're looking for any change in your breast shape, the skin, the feel of the breast. If you check yourself every month, you will learn your breasts, and it takes time. But if you do it several times over, you will learn them and know that, yes, this is now a change and that I need to go tell my doctor about this change.
Thank you. And another question, how important is it to keep up with routine screening?
Well, I think you heard that enough from me, but I'll go over it again anyway. It's okay. No, I don't mind talking about that a lot, actually, because I do, I just said, mammography is the one thing I know I can find things before things become cancerous. So it's the one thing I fully, completely promote. And in fact, every patient who comes in who goes through breast cancer treatment with me usually has to go tell 5 other women to go have a mammogram. Because I do believe that that's the one test I have. And, women sometimes are nervous about the radiation involved with an x-ray of the breast. And really the radiation is very minimal. You could argue that it's the same radiation you get from flying from New York to California, and the people who do it on a weekly basis, well, not now, but I used to do it on a weekly basis. So I feel it's a relatively easy, safe test to do for the breast, other than the bit of the discomfort. It's thankfully quick. There's lots of things we do, like immunizations, which are not fun, they're uncomfortable, and yet we do them. And this is one of those things you kind of just have to check off your little calendar once a year, I feel.
Great. I don't know if there are any more questions coming through. I'm not seeing any. So we can wrap up. If anyone has any last minute questions, please send them now.
Well, I left my address and phone number up there. If you do have questions, you want to chat, you certainly can call that number, and I'm happy to chat with anybody.
Yeah. So I guess we'll wrap up. We appreciate you all tuning in today. This recording will be posted on the St. John's Riverside Hospital Facebook page, so you can pass it on to your friends and family. And as Dr. Sahgal said, we will be at the close of the webinar, we'll be posting her information and the St. John's Riverside Hospital numbers for our 3D mammogram suites. We also have a patient navigator, and so her phone number will be up there as well. Thank you for joining us today. We'll have 2 more webinars this month, one tomorrow on pain management and one next week on stroke on October 29th. So we hope you can tune in. Thank you so much, Dr. Sahgal, and to Sally from Yonkers Newark and Z. Baird from the Yonkers Public Library. Thank you.
Thank you, everyone. Have a good day.
Bye-bye.